So for this first 30 minutes, I'm going to be introducing you actually to the principles of patient-centered care. It's a term that's bandied around an awful lot. It's a term that's often very misunderstood, misused, and hopefully by the end of this 30 minutes I will have clarified some of the things about what it means to provide patient-centered care. I don't for a minute think that in 30 minutes I'm going to actually create a whole room full of expert providers of patient-centered care. However, there are three incredibly important points that I do hope that I get across. The first of these is that you understand that providing patient-centered care is actually a high-level skill. It is not something that's going to come naturally to you. You have to practice it, you have to hone your skills. Some days will be frustrating. It is an ongoing skill that you constantly work on. The second point that I'd like to make is that if you are going to be a patient-centered care provider, you absolutely need to take on board that you are no longer the expert. You are the expert of disease management, but you're not the expert when it comes to knowing what is best for a patient. And the third point, which is quite a hard one that you need to take internally and grasp a hold of if you're going to provide patient-centered care, is that understanding that within the paradigm of patient-centered care, there is no such thing as a non-compliant patient. A hard thing sometimes for many of us to understand. So to put patient-centered care in perspective, let's just take a step back for a minute and put it in its framework of where it belongs. Let's just say that you present to my office. You're complaining of a cough. You tell me that you've been sick for the last 3 weeks. The cough began about 3 weeks ago. It began to get a little bit better, but then suddenly it got worse again. You started having hot and cold chills. But what brought you into the office this morning is that you were feeling particularly short of breath when you woke up. I take your temperature, I find you've got a fever. I listen to your lungs and I find that you're not moving a whole lot of air in your left lower lobe. I scratch my head and I think, shall I send her for an x-ray? Or shall I get some bloods? I decide I'm going to send you for an x-ray. And sure enough, it comes back and confirms that you've got a left lower lobe pneumonia. I give you a Z-pack, I tell you to follow the instructions appropriately, and I reassure you that you will get better. How do I know that this is what I need to do? I know because I've got a body of medical knowledge that I have been given. For diabetes, I have a huge body of knowledge around the pathophysiology of diabetes. I have a huge body of knowledge about multiple diseases so that I know what differential I can put this person on, what tests I need to order. There are all sorts of antibiotics we have out there, but we've done multiple experiments, trials to determine which is the best antibiotic that I need to pick for this person. We have protocols and guidelines. We then take all this body of knowledge and we apply it to the patient, and we then can reassure them, we know because of the experiments that we've done, that she's going to get better. This is our current model of medical care, or as some people call it, our acute disease model of medical care. We do it over and over again. We are really good at it. In fact, we've gotten so good at it that we've created our own monster, which of course is chronic disease. Just as with chronic disease and acute disease are of course quite different from each other. With acute disease, we've got symptoms that come on very quickly. And the person doesn't like having the symptoms, so they actually present themselves into the office, complaining. Fortunately, for many of our acute diseases, for most of our acute diseases, they're curable. We have ways of treating people. We have done experiments to show which are the best ways to do it. We tell the person to follow our instructions. The doctor or the provider is completely in control. Completely different from a person with a chronic disease, which has a slow and insidious onset to the point where the person doesn't actually really realize that they've got any symptoms. So they don't actually come in complaining. They're asymptomatic. We have to go out and look for them. We have to screen for diabetes. When we do find them, the diseases aren't curable, they're manageable. We can minimize their risk of ongoing complications. Unfortunately, when we manage them, we give them things like lifestyle changes and medications that give them symptoms. So they've come in asymptomatic and they've walked out complaining of symptoms. Because the disease is not curable, the patient has it every single day of their lives. They have the ability to wake up every morning and make that decision as to whether or not they're going to take their management as it has been prescribed. The patient is in control. So the two are completely different. However, just as with acute disease and chronic disease, we also have a body of knowledge. In diabetes, we have a huge exponential increase in our understanding about what's going on with diabetes. We also have an amazing exponential increase in medications and insulins that are available to us. They seem to be flying at us. Every single week we seem to have a new one coming at us. We've had lots of experiments done to give us protocols and guidelines about how we should be managing patients with diabetes. We can't cure them, as I said before, but we can minimize their risk. So we have a set of goals that we aim for in order to minimize their risk. And just as with acute disease, we have been trying to apply our body of knowledge to the patient in order to get the outcomes that we're looking for. Unfortunately, as you and I both know, we've not been particularly successful. I wouldn't be standing here if we had been. So what is different about this process of going from our body of knowledge to our outcomes in chronic disease that makes it not work compared to acute disease? This process we call the translation. What is different about the translation from one to the other? And this has become an object of curiosity. It has become the focus of a relatively new body of research called translational research that began probably 15, 20, 25 years ago. And what they were looking for is, how is it that it's different in chronic disease? Without going into the details excuse me, of the research, in the very early days, the results of the research suggested to us that we needed to make some pretty darn major changes in our healthcare system and in the way we provided healthcare. Structural changes. Certainly in the countries where we've got national healthcare systems, public healthcare policies, the changes in them were huge. New models of care began to spring up all over the place. Patient-centered medical homes is one of them that has come out of translational research. Electronic health records are a direct product of translational research. When they went to go and look at how we were doing, whether patients were showing up, what were doctors doing with patients, they found that they didn't have any records. We had no way of tracking patients, and so electronic health records came out of this. And of course, huge restructuring in medical education institutions. I can remember my first day of medical school when the dean got up. It's probably the only thing I remember from her speech that she gave us. It was, "You are the last class of the old curriculum. You mustn't fail because next year the new curriculum we're not able to fit you in." I'm imagining nursing schools and all sorts of other medical educational institutions went through similar huge shifts in the way that they were teaching information so that we could presumably shift the way that we were providing care. Again, without going into the details, we now know that this also has not worked, that these changes haven't produced the outcomes that we need. And so translational research did a bit of a shift and a shuffle, and they changed their focus. And it might sound a little bit strange and naive to you and me today, but they suddenly realized that actually there was a patient in the middle of all this. And maybe we needed to acknowledge that, and of course out came the recommendations that we needed to partner with patients. Again, that hasn't been particularly successful either. And again, with a shift and a shuffle, and I won't take the time to go into the details of the research, they have finally landed on this place where they've said, we shouldn't just partner with our patients, we actually need to provide patient-centered care. So what is it about patient-centered care that is so different from partnering with patients that is going to make that difference that they tell us is going to happen? Patient-centered care is about educating a patient with knowledge, as we have talked about so much in the last few sessions that we've had together. It's about making them well-informed so that they can make the decisions about what they would like to do with their management. It allows them to choose what is best going to suit them. It is also about regarding them, therefore, as the expert when it comes to choosing what is best for them. So patient-centered care is a formal theoretical framework. It's been put together beautifully in this book by a group of Canadians. You're more than welcome to take a look at it later. It's a set of principles, a set of tenets that you're supposed to adhere to at any time that you have a patient in front of you and you're providing care with them. So what are these principles? Well, they're establishing a working relationship, understanding your patient, finding a common language, finding common ground, acknowledge the patient as the expert, and finally empowering the patient to self-manage, putting them in control of their disease. You might be reading all this and going, yeah, sure, that looks kind of logical. That's kind of sort of simple stuff. Actually, I think I kind of sort of do that every day. What I'm going to ask you is that as I go through each one of these and detail each one of these, is really look inside of you and say, is that actually what I am doing with the patient? And I'm going to urge you and suggest to you that maybe it is not quite what is happening. So let's go through each one of these. Establish a working relationship. It seems fairly logical, but we don't do it if we're setting out in patient-centered care. We have to be very careful that we do it. Remember, I just described the scenario of the person presenting with a pneumonia. And if you think about it, when a person first presents with their chronic disease, up until that time, all of their interaction with the medical care profession has been in an acute disease situation. They have sat there, they have expected the doctor or the provider to give them their diagnosis, they've expected to be given a treatment regime, and then they've expected to go out and probably follow it. If you are planning on providing patient-centered care, that's not what you're planning. You're planning for them to make all the decisions. You need to make sure that you shift the roles over and that you allow them to understand what the expectation for them is going to be. The best way I can explain this is to give the example that I give in the diabetes service that I run. When that person shows up in the room, before we even start talking about their diabetes, I say, welcome to the diabetes service. You know, before we get started, I'd just like to explain to you that we do things a little bit differently than perhaps how you've ever experienced this before. Correct me if I'm wrong. You've had diabetes for a long time. If I could just get you to think back about what that was like at that first experience, I imagine it went something like this. I imagine somebody said, gee, I'm really sorry you've got diabetes. Now you're going to have to stop eating these foods. You can eat these ones. You can't do this. I need you to lose 10 pounds. I need you to go to the gym every second day. You must do this. You can't do that. And da-da-da-da-da. And usually by at that point, they're kind of nodding with a little bit of a smile on their face going, yeah, how'd you know? Okay? I said, they prescribed you a lifestyle. I said, we're not going to do that here. We're really lucky these days. We have all sorts of different options, different ways of being able to manage diabetes. And what I am going to do is regard you as the expert because you know the best about what's going to work for you. I am the expert in knowing what's out there. I'm going to share that knowledge with you so that you can decide what you would like to do. Perhaps you like to eat chocolate every night before you go to bed. That's absolutely fine. Just allow me to teach you so that you can have it and still have a normal blood sugar. They usually like that idea and they're willing to accept their new role. So establish your working relationship with the patient. Understand your patient. Every action that a person has is the result of all of their thought processes, their beliefs, and all of their ideas and dreams, really, in their lives. A patient's decision to follow through with taking care of their disease is based on the best decision that they can make with the knowledge and the information that they have. They make the best decision that they can make with the knowledge and the information that they have. We have spent a lot of time talking about how we can share information to make sure they've got the correct information. About 5 years ago, I did a study with a peer of mine, a rural general practitioner. We decided we would interview about 15 people who had diabetes, that had diabetes for years. They were all on insulin. And we basically just started the interview off saying, tell us about your experience of living with diabetes. These were, amazingly, some of the comments that we got from them. Diabetes is just like having a cold, you know. In other words, it'll come right. This guy had diabetes for 14 years. Is he going to take the pills that he's being prescribed? When I take the diabetes drugs, it makes me feel worse, even though it could be long-term, making me live longer. But short-term, it makes me feel bad. The metformin gave me terrible nausea. Dry retching and was, well, why would you want to do this 3 times a day when you feel so ghastly? Is this person going to take their medications? Well, I just feel if I'm feeling good, if I feel my body's feeling good and I'm feeling good, I see myself as healthy, whether I've got diabetes or not. Is she going to take her pills or her insulin in this case? And with the drugs, I do not drink alcohol, I do not smoke. So having to put Western chemicals or medicines, whatever, into the body is something that I'm thinking, why do I need to do this? Why do I want to do this? Is she going to take the medication that she's been prescribed? So it's very important to understand what thought processes they have behind if you're wanting to try and manipulate, it sounds a bit nasty, but if you're wanting to manipulate what they're going to do with their medical management. The best example I've got actually didn't happen that so long ago with a patient of mine. He was a young man in his late 20s, type 1 diabetes, very poorly controlled. He came storming into my office, absolutely furious, fuming. "William, what's the problem?" "Oh, I'm so angry," he said. I said, "What happened?" He said, "I woke up last night. I was incredibly short of breath. I figured I must be really ill. I was dripping sweat. I must have had an incredibly high fever. I thought I must have a pneumonia. I need to get myself into the emergency department." So at 2 o'clock in the morning, he took himself into the hospital. He walked in there and he said, "I've got a pneumonia. I need antibiotics." They ran fluids on him. They gave him insulin. He said, "Where are my antibiotics? I've got a pneumonia." And they looked at him and they said, "No, it's your diabetes." He was so angry that they wouldn't treat the pneumonia. He actually, in the end, ripped out his IV and came to his appointment with me. I said, "Oh, well, hello, William. How are you feeling now?" "Actually, I'm feeling a little better," he said. He said, "But I am incredibly angry. Why would they not give me antibiotics? Everybody blames my diabetes for everything, and they never treat me for the right thing." I said, "Has anybody ever talked to you about ketones?" He said, "No, I've never heard of them. He'd had diabetes since he was 8. I said, "Would you mind if I just spent 5 minutes explaining to you diabetic ketoacidosis?" Which, of course, I did then. He allowed me to. And at the end of it, of course, he understood that if you have DKA, you have Kussmaul breathing. You sweat profusely. And that, indeed, his presentation was DKA, not a pneumonia. His response at the end of my explanation was, "Why the hell didn't they tell me that at the hospital?" And I said, "Well, actually, William, they did. They told you it was your diabetes." He said, "But I didn't understand." I said, "Actually, what they didn't bother to do was to understand where you were coming from in order to help you and assist you make the right decision. Understand your patient so that you can help and assist them." A patient's decision to adhere to a medical regime is a complex human behavior that is facilitated and or hindered by many factors: fears, beliefs, life's demands, and of course their understandings or misunderstandings around a disease, such as in William's case. The third principle is to find a common language. Again, up front, this looks incredibly simplistic and simple. It's about making sure that when you're communicating, the person is understanding, and as many of you now obviously know, this is my way of doing it with the person. Do make sure that you put them on the same page. Start right at the beginning. You have to be very careful not to insult a person. In my case, where I'm meeting people for the first time and they've had diabetes for many years, I generally broach this problem of needing to go back to basics with, "You've had diabetes for many years. I imagine you know an awful lot about it. I also know a lot about diabetes, but we probably use a very different language in order to talk about it. Do you mind if we just go back to basics, to Diabetes 101, and let's just spend 5 minutes. I'm going to go really quickly. You slow me down if you need to. We're just going to go very quickly, and we're going to make sure that we're using the same language." And most of them are very amenable to that. Incredibly important, because it doesn't matter how many years that they've had diabetes, you will find that you are using a different language, and that is where you're going to lose them on the way. Not only that, you will find that they have lots of knowledge gaps that you can then help them to fill it in. All right? Many of you may have your own way. This is not the only way, okay? I'm not holding this up as the gold standard, but just find your way of establishing a common language for people. Finding common ground is the next one, and this is probably the hardest principle of patient-centered care, not only to hone, to get good at, but it's the hardest one for me to teach, okay? Very simply, it can be thought of as finding the patient's motivator, but it's actually more than that. It's finding a patient motivator that puts them on the same page as you, that puts them on the same road towards a better HbA1c. Many of us have a tendency to try and give the patient their motivator. You know, if you don't take care of your diabetes, you're going to go blind. Or if you don't take care of your diabetes, you're not going to be able to see your grandchildren grow up. We love to provide them with their motivator. That's not going to work. You need to find their motivator, or you need to really find the one that's going to work for them internally, okay, not an external motivator. The one that I have found that works the best for most people is providing them with an explanation of HbA1c. I say to the person, you know, your doctor sends you for this blood test every few months. Do you have any idea what he or she is sending you for? Most of them actually look at me pretty blankly, even though they've had diabetes for years. A few might say, oh, I think it's a fasting cholesterol. Even fewer actually will say, something to do with my average blood sugars over a certain period of time. And I go, you got it. One of the tests is the HbA1c. And one of the things that it does tell you is your average blood sugar over a period of 3 months. However, there is a far more important thing that it tells you. It actually gives you your risk of having a heart attack or a stroke within the next year. And look at this, Mr. Jones. Your HbA1c is 10%. If I take you down from 10% to 9%, I am going to reduce your cardiovascular risk, your risk of having a heart attack or a stroke, by 27% per year. If I take you from the 9% down to the 8%, it is another reduction of 27%. Look at you, if normal is 5%, you're kind of a sitting duck, and most of them are fairly appalled. Most of them don't want to have that risk, and obviously you need to explain to them what a 27% risk means, but most of them get it. That is their motivator, and usually their next comment is, what the heck do I need to do in order to improve my HbA1c? Of course, sometimes it doesn't work. I would say quite often this doesn't work. Okay? And that is where the skill of patient-centered care, your art, comes into being. Many times people's internal motivators have absolutely nothing to do with diabetes, and that is where you need to dig and understand your patient and find what their motivator is. One of the examples I love to give for this is a young man also with type 1 diabetes in his first couple of years. I think he was 22. He had had diabetes since he was also 8. He'd always been relatively well controlled, but in the last couple of years we were really struggling with getting his HbA1c back under control. On this most recent visit that I had with him, he said that he really actually just couldn't be bothered with it. He actually didn't have time to check his blood sugars. He knew he should. He knew what he needed to do. His knowledge base was absolutely fine. He just couldn't be bothered with it. And I said, oh, are you really busy? And he said, oh, yeah, he said. And it turned out that he's a drummer in a rock band. And in fact, a very good rock band. And they're becoming quite popular in New Zealand. And they've got about 2 or 3 gigs every couple of weeks. And they are practicing furiously to build up their repertoire. I love to practice, he said, especially on those days when my timing is really good. It's just such a thrill when you get it right, you know. And I said, oh, so you have days when your timing isn't very good? Oh, yeah, that's kind of frustrating, but you know what? You just practice more. And I said, you know, Peter, has it ever occurred to you to test your blood sugar on those days where your timing is off? There's a whole body of research out there that tells us that if your blood sugar is greater than 140, your coordination and your reaction time just isn't there. Really, he said. To cut a long story short, this guy now checks his blood sugar about every 2 to 3 hours through any kind of gig, any kind of practice, and we've got a really nice, good-looking HbA1c. Common ground. He had a completely different motivation for checking his blood sugars, but it put him right in line with what my motivation was. Okay? That is finding common ground. You need to acknowledge your patient as the expert. As I said before, a person's actions are the final result of a whole lot of things that are feeding into them. And the best example that I can use for this, for this whole idea that a person truthfully is the only one who's going to know what really is best for them. Is an example that is unrelated to diabetes. You know, I drive a Toyota Corolla. It's kind of a beaten up Toyota Corolla, but it's got 4 wheels. It does a great job of getting me where I need to go. It's cheap. I've never had to spend a whole lot of money on it. It's got a couple of dings in it, one on one front corner from one child learning to drive, and the other one on the other corner from the other child learning to drive. But it's great. I love it, and it's fine. It gets me where I need to go. In fact, I have the attitude of, why would you spend a whole lot of money on a posh Mercedes or an Audi? What a waste of money. But if I happen to take the time to stop somebody who has chosen to spend a whole lot of money on their posh car, perhaps I might find out that their decision was not based on the fact that they wanted to be a snob, but was based on the fact that actually they wanted a safe car for their kids when they were out on the highway. They wanted a car that had excellent airbags, which my car doesn't have. But my response is, that's not going to convince me that I need an expensive car. I'm a safe driver. I'm a good defensive driver. I'm just fine. Now, half of you in the room might go, well, that's a pretty stupid decision, okay? But that's my best decision. I'd rather spend my money on something else. I might bump into somebody else who also drives an expensive car and happen to ask them, why have you spent all your money on your expensive car? And their response to me might be, I love music. And I love it when I'm in the car that I can shut the windows and not hear any of the tire noise on the ground and can completely go into my own little world. I go, oh, I love music. I would love to be able to do that. I hate it in my Toyota. Every time I go over a bump, my CD skips. And maybe I will then go out and buy an expensive car. But only I know what's going to change my idea and change what's going to happen with my behavior. Do treat your patient as the expert in knowing what's best. And finally, the final and very important step in patient-centered care is that you do need to empower your patient. We've talked about the need to give them the understanding of the pathology and understand how the medications work. Give it to them in detail. Give it to them accurately so that they can make the right decisions for themselves. We need to make sure that they understand that their diabetes is progressive, so we need to give them the tools where they can check their blood sugars and change their medications to match their blood sugars. Teach them how to do a correction factor. We've talked about this, how they can bring their blood sugar back down to the normal range. We can provide them with instructions on how to escalate or change their own medical management. They don't need to come back and see us all the time. Do provide them with these tools so that they can totally self-manage their disease. Finally, do give them all the information that is out there. Don't just pick and choose. Don't decide what you think they should know. Give them all the information so that they can make the decision about whether they want to spend the money on an insulin pump. That's not your decision. That's their decision. And of course, if you are going to send them out there, you must go ahead and provide them with parameters so that they feel supported and safe in their own self-management. Empower your patients to go on with their own management. Whoops. Does patient-centered care work? Absolutely. I'm a real believer in it, as you've probably noticed. In the Diabetes Service in New Zealand, we've been tracking our outcomes, and in fact, we're just about to come out with our 4-year data here. With type 2 diabetes, soon after we have seen them, we've got an average decrease in HbA1c of 2 percentage points, and this is regardless of their ethnicity, whether they're Maori, Pacific Island, or Pakeha, which is European New Zealander. We have tracked them even though we have not seen them. We have had nothing to do with them. And they have continued to hold their change in their HbA1c. And I just reviewed the data in the aeroplane on the way over, and it looks very likely that we're going to be sitting at exactly the same average change. Patient-centered care truly does work, and it is long-term change for the patients. So what is it that we need to do in order to take our body of knowledge to get the outcomes they want? What I'm suggesting is we need to provide patient-centered care. Providing structural changes, such as putting a patient-centered medical home in place, is not necessarily, in fact I'm going to say absolutely will not get you the outcomes that you're looking for. Until you change the behaviour of what's happening behind that closed door between you and the provider, you are not going to be able to get the outcomes that you're looking for your patient. Thanks very much.